So thank you everyone for joining us. Thank you all attendees for joining our webinar today. We're very happy to have this webinar in cooperation and collaboration with Dr. Zeina Tannous, the renowned speaker, and Dr. Firas Al-Niaimi. We actually thank them as well for this opportunity to share experience from Western region and from Eastern region as well. So my name is Mohammed Fouad. I will be the moderator for today's session, and we'll be talking about vascular lesions overall and rosacea in specific. Before we start, I would like to remind everyone that you can ask your questions and direct them to our speakers during the session. You have that question mark symbol either using your PC or using your mobile. You can click on it, type your question, then go back to watching the presentation. We'll be saving all the questions and we'll answer as much as we can during the panel discussion with our doctors. So first of all, I'm happy to introduce Dr. Zeina Tannous. Dr. Zeina is a renowned consultant dermatologist in the Middle East region. She is US board certified in both dermatology and dermatopathology. She's holding 3 Harvard fellowships in laser, dermatologic surgery, and dermatopathology. She is a well-known publisher and an author of more than 70 scholarly articles, and she co-authored a cosmetic and laser textbook as well. She's a board member of multiple prestigious societies, and she's also an editorial member or board member in a laser and surgery medicine journal. She is also a regional, national, and international speaker, and she delivered a lot of lectures in several conferences and in several exhibitions. And also today we have Dr. Firas Al-Niaimi, who is a well-known consultant dermatologist practicing in London in Harley Street, and he's also affiliated with NHS, and he is one of the most renowned speakers worldwide. Dr. Firas Al-Niaimi is a fellowship-trained dermatologist in laser and dermatological surgery. He was awarded last year, and congratulations to him, the Global Excellence Award for the Consultant Dermatologist of the Year 2019. Dr. Firas is a keynote speaker in 200 conferences, and he spoke in more than 55 countries around the world, has written and contributed to more than 160 publications, and he authored his own books and actually co-authored several chapters in different publications. He is an honorary consultant at the world-renowned St. John's Institute of Dermatology. So I welcome both our doctors, and I thank them for joining us today. I'll be handing over to Dr. Zeina now to start her presentation. Dr. Zeina.
Good afternoon, everyone. I'm glad to be giving this webinar today, and I will be talking about rosacea. We'll focus on rosacea. I'll be talking about all aspects of rosacea, and I will leave the laser part for Dr. Firas. So we start. Will I be able to advance my slides, or you will be doing that?
Yeah, I'll be assisting you, doctor. Take your time in each slide and just let me know when you need to move.
Okay. So rosacea is a chronic inflammatory disease of complex pathogenesis lasting for years. The exact cause is still unknown. However, there is recent evidence of a multivariate set of pathogenic pathways, including defects in innate and adaptive immune systems, mast cells and related biochemical mechanisms, and most importantly, the neurovascular system. There's also a significant increase, as we all know, in the hair follicle mite, Demodex follicularum. Next. Next. Rosacea occurs after age 30 usually. However, it may develop at any age. It affects mainly the central face, including the forehead, the cheeks, the nose, the eyes, and it's more common in women than men. It's many times it resembles acne, and usually it's important to get a patient history of flushing, redness, and failed acne treatment because of misdiagnosis, as well as family history. Next slide. The symptoms of rosacea include flushing, erythema, edema, papules and pustules, telangiectasias, rhinophyma, ocular involvement with no comedones, unlike acne. The patient may present with either one or a combination of these symptoms, and can also be asymptomatic completely or can complain of burning, stinging, pain, or pruritus. Next. The disease course typically shows remissions and exacerbations all the time. In fair-skinned individuals, the disease has prevalence of up to 10%. However, it's not limited to fair-skinned individuals only. It may be seen in skin of color. In fact, in darker skin types, the persistent erythema is sometimes hard to visualize, and it's reported less by patients than papules and pustules. Next, please. Up to 10% of rosacea patients have colored skin, in fact, and 6 in 10 people consider their rosacea to be extremely bothersome to them. The current treatments are many. They include prescription creams and gels, over-the-counter creams and gels, homeopathic and alternative medicine, oral antibiotics, and laser therapy. And in a survey of patients, 74% of these patients are not satisfied with their rosacea treatment. And interestingly, 59% of these patients did not know that you could use lasers for treatment of rosacea. So now more about classification, and I thought it's interesting to familiarize you with the new classification of rosacea. Next, please. The standard classification and the pathophysiology of rosacea was published in 2018 by a consensus that happened in 2017 by the National Rosacea Society Expert Committee. Next. So initially, as we know from before, that the disease was classified into 4 subtypes: erythema telangiectatic type 1, papulopustular type 2, Ecchymosis subtype 3 or type 3, and ocular rosacea, which is subtype 4. And granulomatous rosacea was considered as a variant of rosacea rather than a subtype. However, not only a subtype may progress into another subtype, but also these subtypes may occur simultaneously at the same time. So really, rosacea is a continuum of the disease or symptoms, not rather different subtypes. So as you can see down, we have the erythematotelangiectatic rosacea, where you have redness and telangiectasia. Next to it is papulopustular, papules and pustules on the face, central face, and rhinophyma, which is the enlargement of the nose. Next. So in 2017, there was a shift from these subtypes to phenotypes in the diagnosis of rosacea. And to diagnose rosacea, you need to have at least one diagnostic criteria, which I will mention now, or 2 major phenotypes. These are required in order to diagnose a patient with rosacea. And look at the table down, you can see that the diagnostic features are fixed centrofacial erythema in a characteristic pattern that may periodically intensify. And the second diagnostic feature is ecchymosis changes. So in other words, if you have one of these, you have rosacea. The major criteria include flushing, papules and pustules, telangiectasia, and ocular manifestations. And if you have 2 of these, then you have a diagnosis of rosacea. The secondary symptoms include burning sensation, stinging sensation, edema, dryness of the face, and ocular manifestation. But these are only complementary, they're not diagnostic. Next. And this is an example of erythema of the rosacea in a white skin. So it's easily identifiable on white skin. And on the right, you can see the papules and the pustules that are also very clear on white skin. Next. However, in Asian skin or Latin American skin, you can barely see erythema, as you see in figure 2 here. And in figure 3, you only see erythema and papules and pustules much more than the erythema in a patient of Latin American origin. Next. This is an example of ocular rosacea, just to show you that it can definitely, we can have these crusts and the telangiectasias on the eyelids. So always look for ocular rosacea when you're suspecting a patient with this diagnosis. Next. And this is an example of ecchymosis changes in an African American patient, African skin. This sometimes can be confused with sarcoidosis or other granulomatous disease, so have high index of suspicion, and sometimes in these cases a biopsy might be needed to confirm the diagnosis. Next. Ecchymosis changes include hypertrophy of the sebaceous glands, as well as proliferation of the blood vessels and connective tissue components, and it's commonly on the lower third of the nose. Next. And as I mentioned, this is diagnostic of rosacea. Now, I thought of sharing with you some the things that can, or the diagnosed skin diseases that can also mimic rosacea. Acne vulgaris for sure is number one. Always look for comedones. If you don't see comedones, it's unlikely to be acne. Contact dermatitis is the second differential diagnosis. Photodermatitis, seborrheic dermatitis can easily be misdiagnosed as rosacea, and systemic lupus erythematosus. Next. What about management? These two articles I found that are very recent. They were published in February 2020, and they provide a nice summary of the management options and update in treatments of rosacea. Next. So management includes lifestyle management, skincare, drugs, laser and light devices, and ocular rosacea management, which we will not be discussing in this lecture. Next. So as we know, the rosacea triggers, and this was a survey that found that sun exposure is the most common trigger, followed by emotional stress, hot weather, wind, heavy exercise, alcohol consumption, hot bath, cold weather, spicy foods, humidity, indoor heat, and certain skincare products. So by avoiding these triggers, by managing our lifestyle, we can help our rosacea. What about skincare? Gentle skincare is essential. Why? Because patients with rosacea often have a very sensitive skin that can be easily irritated, causing redness, burning, and stinging that are very bothersome. So the goal of daily skincare is to maintain the integrity of the skin barrier with the proper moisturizer while avoiding agents that can aggravate inflammation or flushing. Next. Always have to use sunscreens. As I mentioned before, the most important trigger is sun exposure. So you should use sunscreens all the time, and preferably these sunscreens should be mineral inorganic sunscreens, such as zinc oxide or titanium dioxide, because simply these sunscreens do not produce heat as a byproduct, so they don't exacerbate rosacea, and they provide a physical barrier rather than an irritating chemical sunscreen. Next. What about cleansing of the face? Gentle cleansing regimen is important to avoid irritation. So we advise the patients to wait for the face to dry before applying any topical therapy so that they will not have stinging. Cosmetics can be used. They can choose the green or yellow tinted cosmetics that may reduce the appearance of redness. Next. And this table summarizes the skincare regimen for rosacea patients with skin off color. So gentle, non-alkaline, fragrance-free emollient cleanser once per day in the evening usually, silicone-based moisturizer, light water-based cosmetics, physical sunblock, and they should avoid alcohol-based cleansers, astringents, or abrasive exfoliating cleansers, and non-silicone-based moisturizers and cosmetics that are irritating to them, and chemical sunscreens. It's better if they use the physical sunblock. Next. Now coming to drugs. They can include topical, oral, and often they're initially prescribed in combination. Then they are followed by long-term use of a single therapy alone, which is usually the topical medication to maintain remission. Next. So starting with the topical drugs, the FDA-approved topical therapies for inflammatory rosacea include azelaic acid, ivermectin cream, metronidazole, sodium sulfacetamide in various formulations. Others that are not FDA-approved for rosacea include topical pimecrolimus, retinoids, which can be very irritating, so we don't usually use them, but they've been used in certain resistant cases, and permethrin cream. Next. What about oral drugs? Oral drugs that have been FDA approved is doxycycline, and basically, or specifically, the slow release doxycycline, the low dose one, the 40 milligram, which releases 30 milligram immediately and 10 milligram as delayed release. And these doxycycline is approved by the FDA for the treatment of inflammatory papulopustular rosacea. Why it's interesting to, or it's beneficial to use the low dose? Because lower dosage is lower than that which is used to treat infections, which gives us less bacterial resistance and fewer side effects, and it is safer to use for long-term use. Next. Second-line therapy include the following, and these are used when first-line treatments are inadequate or when the rosacea is very severe, and they include oral antibiotics, off-label oral antibiotics, and retinoids, such as tetracycline, minocycline, azithromycin, clarithromycin, and oral isotretinoin. And you can also use zinc sulfate, oral zinc sulfate, and oral ivermectin with success. Next. Filamentous changes, when we have these changes, sometimes a low-dose doxycycline can help, as well as a low-dose isotretinoin. I'm talking about 20 milligram per day approximately, or 0.3 milligram per kilo per day, with the level A evidence. Next. What about facial erythema of rosacea? We know that the erythema does not improve on oral antibiotics and the topical creams that we mentioned before. So the FDA have approved two topical therapies in adults, the brimonidine topical gel, 0.33%, which is an alpha-adrenergic receptor agonist, and the oxymetazoline hydrochloride cream, also it's an alpha-adrenoceptor agonist. And other off-label use drugs have been prescribed to help control flushing, include non-steroidal anti-inflammatory drugs, antihistamines, clonidine, and beta blockers in severe cases of flushing. Next. I thought that this is an interesting information to tell you about an intradermal botulinum toxin type A Botox injection. This has been only reported in few patients, up to 18 or 17 patients so far, but it is a promising treatment modality that helps in the decreasing the release of acetylcholine. As you know, that the release of acetylcholine leads to vasodilatation of cutaneous vessels, hence it makes the erythema more prominent. So by using Botox, it interferes with the release of acetylcholine and provides relief for the patient's flushing and facial erythema. And so 17 patients have been successfully treated. The units were between 15 and 65 units, and these are the two references. And the results were achieved 1 week after the second session and persistent. So that's an option to keep in mind, but make sure that it's only intradermal injection, very superficial, not going to the muscles, then it will be a huge problem. Next. So the targets chromophore and vascular are effective, and light sources, of course, are effective in treating vascular lesions, and ATP and Diag, alexandrite, diode, and IPL. Next. Pulse dye and potassium titanium phosphate, KTP laser, these are highly effective in removing telangiectasias and diminishing erythema. Intense pulse light has been proven to be effective in reducing flushing. Ablative lasers such as CO2 laser and erbium laser, as well as radiofrequency and surgical shaving, have also been found to be appropriate for removing tissue. Keep in mind that all laser therapies should be used with caution only by highly trained professionals in patients with darker skin, who are prone to more side effects. Next. So for flushing erythema and telangiectasia, the pulse dye laser is used, and it has two settings. Either you can usually produce the purpura or purpurogenic doses that produce improvement in less time. However, it's not feasible for the patients, and you can use the sub-purpurogenic doses, but more sessions are needed. Next. And these are the endpoints of pulse dye laser. On the left, you can see the purpura from the externalization of RBCs and sometimes from vasculitis induced by the laser. And on the right, you can see the facial erythema with the subpurpuric energies that resolves in a few hours. Next. And I thought of sharing a case of mine of rhinophyma. Rhinophyma is, I think, in my opinion, is best treated with the surgical modalities, whether it's CO2 ablation, erbium ablation, or just loop cautery, as I've used in this patient. Usually I mark these bulbous components of the nose, and this is the result, a side view of the rhinophyma. And again, very good results. So the aim is to shrink, to restore the shape of the nose to what it used before, not to shrink the nose a lot. So we don't want to change the shape of or the character of the patient, but to restore it to how was it before. Next. And I believe this is the last, my last slide, and I give the floor to my colleague, Dr. Firas.
Okay.
Thank you, Dr. Zeina. Welcome, Dr. Frost. How are you?
Good, thank you. Can you hear me?
Yeah, I can hear you properly. I just wanted to remind our 350 attendees that you can ask your questions. And after Dr. Frost's presentation, there will be a panel discussion between Dr. Zeina, Dr. Frost, and you can ask them your questions starting now, and we'll address the questions at the end of the session. As a reminder, to ask your questions, you can use the question mark symbol or icon either on your phone or on your desktop, according to the device you're using. So I'll leave the floor to Dr. Frost. Thank you, Dr. Frost.
Thank you. Thank you very much. Good afternoon, everyone, and thank you for listening to our webinar. And thank you, Dr. Zeina, for doing such a great job and giving such a great overview of rosacea. So that makes my my job much easier. So if I could go to the next slide, please. So in my half of the talk, I will be concentrating more on the lasers because we've heard from Dr. Zeina about rosacea and the different treatment modalities. But what I would like to do is to just give you tips and share some pearls with you about how to maximize the use of the pulse dye laser and how to successfully use the pulse dye laser in the management of rosacea. But before we talk about the pulse dye laser, I just want to share this timeline with you because often we as dermatologists, as doctors, we have a laser in front of us. We tend to take the laser for granted. We just think it works brilliantly, but often there's a story and there's a history behind it. So remember, anytime we're using pulsed lasers, we are actually adhering to the selective photothermolysis theory, which is essentially trying to heat a target without unnecessarily damaging or excessively heating the surrounding. So it's selective heating of a target, which in this case, in vascular cases, it is the selective heating of blood vessels by which the oxyhemoglobin is the main biological target. Now, so all of you, any one of you who uses lasers should be familiar with the Rox Sanderson and John Parish's seminal article on selective photothermolysis in the early 80s. And Candela was the first company to devise then a vascular laser based on the selective photothermolysis theory, which was the pulse dye laser. But the reason I'm showing this slide is to just show you the evolution of the wavelength of the pulse dye laser. So very early on in the 80s, we had the 577 nanometer, because if you look at the absorption coefficient, the 577 has a higher absorption to oxyhemoglobin compared to the 595. So an astute observer will ask the question, why are we using 595? Why can't we use the 577? Because of the higher absorption. But the problem with that is, it is a very simple basic laser physics rule that we all know. The shorter the wavelength, the shallower the penetration. In other words, the longer the wavelength, the deeper the penetration. So although the 577 is highly absorbed by oxyhemoglobin, it's also fairly superficial and it's highly absorbed by the epidermis. So there were some epidermal problems, particularly if you have darker skin types. So then they shifted the wavelength to 585. And what Candela did in 1996 is exactly what we would expect from good companies to do, is to throw it back to the doctors, because the dermatologists were coming back with their feedback. So Candela said, okay, this is a device with 4 different wavelengths, and we would like to find out what is actually the sweet spot. What is the best wavelength for vascular lesions? And the best wavelength which was chosen was 595. And that was chosen based on depth of penetration. So once again, 595 is longer wavelength compared to 577. So it's penetrating a bit deeper, which means better coagulation of facial vessels, but also based on safety, because the 595, because it's penetrated a bit deeper, it's less avidly absorbed by the epidermis, which contains the melanin. Okay, once again, the shorter the wavelength, the higher the absorption for melanin. So melanin is going to absorb higher at 577 compared to 595. So what was found then by using the 595 wavelength is that there was better coagulation due to the better penetration, and also increased safety and less epidermal injury. So this is the reason why the 595 is the best wavelength for vessels, okay? Because it has a unique depth of penetration, not at the cost of epidermal absorption. Now, I'm very fortunate to be the first doctor in Europe to have the Vbeam Prima, which was launched just over a year ago, and that's a unique platform because it has now the two main vascular wavelengths. So in addition to the 595, the pulse dye laser, it also has the 1064 Nd:YAG. So the 1064 Nd:YAG is not what we are going to talk about today, because today we're just going to be focusing on the pulse dye laser, because that's the wavelength of choice in managing facial vessels and rosacea. However, the 1064 can certainly be used for the deeper vessels, such as in the legs and venous malformations, although it requires a little bit more experience given its potential for complications. So from now on, I'm going to be talking about the 595. Can I have the next slide, please? So for those of you who are interested, please, you can get this article. You can get this from IMDAD. And this is an article that I have published in Prime journal, which essentially explains the key features of the Vbeam Prima. In other words, if you're thinking, why is the Vbeam Prima better than the other existing vascular lasers in the market, such as the yellow laser or another type of Nd:YAG or the KTP, read this article, because in this article, I describe the key features of the Vbeam Prima based on the evidence as well as the science. Can I have the next slide, please? So I don't want to spend too much time talking about the device itself, and I want to go to the practical aspects, but just this is the only slide in terms of the key unique features of the Vbeam Prima. So we have two wavelengths, the 595, which, as I explained to you, is the best wavelength for the facial vessels, the 595, and then we also have the Nd:YAG 1064 for the deeper vessels. So in one patient, you might require both wavelengths. If you have superficial vessels, we're using the 595. For the deeper component vessels, venous lesions, we can use the 1064. We also have two methods of cooling. Remember the DCD, which stands for Dynamic Cooling Device, which is a cryogen spray to pre-cool the surface of the skin before the light comes in. That's a patent of Candela, and it's unique to Candela. But we also have the contact cooling handpiece, which I really love, particularly for darker skin patients or for very sensitive patients. The contact cooling handpiece is good. And this is why I'm keen to talk about it when it comes to rosacea, because many of my patients with rosacea, as Dr. Zeina already explained, have sensitive skin. And they find that with the contact cooling handpiece, it's a bit more gentle on them. So I have treated several patients initially with a split face study, half of the face with the DCD, the other half with the contact cooling, and those patients who, all of them reported that this side with the contact cooling was better. I also like it, particularly if I would need to do some compression for some of the very thick lesions, because I can gently compress with the window. It has also a longer dye life, and it's faster in speeds, a larger spot size, and that's very important, and I'll be explaining this in one of the coming slides. So the current Vbeam Perfecta really, although it goes up to 12 millimeter in terms of the larger spot size, practically most of us will be using the 10 millimeter, because with the 12 millimeter spot, you require also a bit more energy. Whereas with the Vbeam Prima, we can go up to 15 millimeter spot, but not at the cost of lower fluences. So even with a 15 millimeter spot, I still have enough fluence to get a biological response. Can I have the next slide, please? So this is just, again, to reiterate that the 595 is the sweet spot because it's a better wavelength in terms of depth of penetration if we compare it to the 577, 585, or the 532, which is the KTP. And it's also safer on the epidermis because there's less epidermal absorption compared to the 577 and the 532. So that's why the 595 is the ideal choice of the wavelength. Can we go on to the next slide, please? Okay, so I see a lot of rosacea patients. I see them every week, and not just the lighter skin type patients, although many of the light skin type patients do suffer from rosacea or just even facial erythema, but also the darker skin types. So if you have the pulse dye laser, how will you treat rosacea and how does it work? So as Dr. Zeina already explained, the target is the oxyhemoglobin. In other words, when we shine the light from a laser, that light needs to be absorbed by a target, which we refer to as a chromophore. So the biological target is the oxyhemoglobin. And what happens then? There's conversion of the light into heat. The light energy from the pulse dye laser is then being converted into heat. And heat is actually what's going to give us the results, which is coagulation of the vessels. Therefore, it is absolutely essential that the settings are correct. I travel around the world and give workshops and lectures on vascular lasers. And one of the things that I always notice is that many doctors find vascular treatments with lasers more challenging. They will say that they feel more comfortable with fractional or pigment, but particularly with vascular, they find it a challenge. And that is because the settings are really important, and particularly the pulse duration. And we'll be explaining this. I just want to highlight the fact that the pulse dye laser is not just for primary vascular conditions. So it's not just for vessels, rosacea, or even port wine stains and hemangiomas. There are numerous non-primary vascular conditions that can be treated with the pulse dye laser, and we'll come to this at the end of the talk. So Dr. Zeina already explained that there are two ways of treating rosacea with the pulse dye laser. You can either destroy the individual blood vessels, so this is where you get clinically purpura, so you get bruises. Now, I almost never do that now, because A, many patients don't want purpura, but B, you need to be particularly careful if you have higher skin types, because when you get intense purpura in a darker skin type, there is also risk of post-inflammatory hyperpigmentation. So pretty much all of my rosacea treatments are in non-purpuric settings. But remember, you need to coagulate the vessels. Vessels will coagulate at a temperature around 65 to 70 degrees. So unless you get the right temperature, you will just get reversible heating of the vessel, and this is why the vessel will remain open. So I will explain to you how we can get to the correct settings. So the way I treat rosacea with a pulse dye laser is with the so-called subpurpuric setting. So that is the combination of the pulse duration and the fluence, of course, with the right spot size, that gives you coagulation of the vessel, but without destruction of the vessel. So you don't get the purpura, but you get the coagulation. And generally speaking, if you're 1 or 2 joules below the so-called purpuric threshold, so that is the fluence for the given spot size and pulse duration that's going to give you clinically purpura. If you go 1 to 2 joules below that threshold, you are in the range of subpurpuric, and that is the best range for coagulating vessels. The reason being is because when you get purpura, you're getting steam formation within the vessel, and that steam formation gives that mechanical rupturing of the blood vessel that gives us the purpura. And that steam formation occurs when the temperature within the vessel has exceeded 100 degrees, because that is the temperature that is required for water to boil and evaporate. So when we are 1 to 2 joules below the purpuric threshold, we know that we are below 100 degrees, but we are very likely to be close to 65 or 70. In other words, we are likely to be between 60 to 100 degrees, okay, and which is exactly the temperature that is required for coagulation of the vessels. There were very nice, elegant studies from the 80s that showed that if you heat the vessel for at least 1 millisecond, just at least 1 millisecond, to 65 degrees Celsius, you get intraluminar thrombus formation and you get endothelial vessel wall destruction and damage. And this is how we can successfully treat vessels. So, next slide, please. Okay, so this is what I always like to teach, and this is what I always like to share, and I would like to spend a few minutes explaining this. to make the approach to the settings for vascular treatments in general easy. First of all, you're going to have to choose your wavelength. For most of the facial vessels, for rosacea and telangiectasias on the face, in this case, it's the 595. But if you're dealing with deep vessels in the leg, for example, you're going to choose the 1064. So assuming that we're treating, for example, rosacea or a vessel on the face, we're choosing the 595. The next thing to do is to choose your spot size. That's the next thing to do. Now, for individual linear vessels, we have a unique 3 by 10 millimeter linear elliptical spot size, so we can choose that. Or if it's just diffuse redness without visible vessels, then you can use the 7 or a 10 millimeter spot. So the spot size, if it's a small lesion, if it's a small molluscum, you can go for a 5 millimeter spot. But if you want to get depth and coverage, minimum 7 millimeter spots. However, now with the Vbeam Prima, I'm using the maximum, which is the 15 millimeter spot, because I will show you why depth is important. Then you are going to choose your pulse duration. And it's very simple. If you want purpura as a clinical endpoint, and there are some conditions where getting purpura is going to give us better results. Port wine stain is an example. Hemangiomas is an example. Hypertrophic thick scars is another example. Then we are going to choose a short pulse duration. So 1.5 millisecond is a very nice pulse duration for purpura in adults. If you have an infant, a baby, for example, with port wine stain, then you can use the 0.45 because the vessels are much, much smaller. But in general, the message is a short pulse duration, and a 1.5 millisecond is a good default pulse duration. If you want coagulation, then you are going to use a longer pulse duration. Okay, so 6, 10 milliseconds are good. If you see a vessel, we'll start with 10 milliseconds, and I'll explain why in the next slide. Otherwise, if you just see diffuse erythema, 6 milliseconds. After 2 or 3 sessions, and in very fair skin patients with very light pink rosacea or erythema, you can go down to 3 milliseconds. So to summarize, for the pulse duration, it's going to be 6 milliseconds if it's just diffuse erythema with no visible vessels. If you actually see vessels, it's going to be 10 milliseconds. And if it's very, very light, faint pink erythema, then it's 3 milliseconds. And then, of course, the fluence is important because you need to see the endpoints. And I will show you the endpoints in the next slide. And please don't forget the cooling. As you increase the fluence, you are increasing the heat. So the heat that you generate with a 7 joules per centimeter square is going to be different from 12 joules per centimeter square. So where there's more heat, there needs to be more cooling. So please remember also, and this is why I put it at the end, because it will depend on your fluence. And I guarantee you that if you systematically, with every vascular lesion, go through this algorithm, you will succeed, and you're likely to think, reflect, and then start to choose the right parameters, and things will going to get very easy from now on. Can I have the next slide, please? So as I said, whenever we are using pulse lasers, we're dealing with thermal relaxation time. And a very simple physics equation is, in terms of the thermal relaxation time for the vessels, is the square of the diameter of the vessel. So in other words, we all know that smaller vessels have a shorter thermal relaxation time, whereas a larger vessel has a longer thermal relaxation time. Those of you who, for example, use Nd:YAG for leg vessels will know that if you have a very small spider vein, you're using a shorter pulse duration, whereas for a large reticular vein, you're using a longer pulse duration. And this relates to the thermal relaxation time. So if it's a square of the diameter, we as human beings can only see a vessel in our naked eye when it's a minimum of 0.1 millimeter in diameter. When a vessel is smaller than 0.1 millimeter in diameter, we don't see it as a vessel, we just see redness, we just see a blush. So when we see individual vessels, that means the vessel is minimum 0.1 millimeter in diameter. So if you then have the square of that, you will come out to 0.01 in seconds. And if you convert that into milliseconds, you reach 10 milliseconds. And this is what I've been explaining. If you see a vessel, you'll start with 10 milliseconds. And that is because the vessel is minimum 0.1 millimeter in diameter. Therefore, the thermal relaxation time is going to be 10 milliseconds. If you don't see a vessel, so that is the situation of diffuse erythema, rosacea without discernible vessels, that means that all that blush and that diffuse erythema is composed of very small fine vessels with a diameter smaller than 0.1 millimeter. So by definition, the thermal relaxation time is going to be shorter than 10 milliseconds, and this is why we'll use a 6 millisecond. I hope this is now clear. Next slide, please. Okay, so this is an example. Once again, if you see a vessel, 10 milliseconds, take it from me. And you need to see an endpoint. You need to see a change. Something needs to happen with the vessel. Something needs to happen with the vessel. Darkening of the vessel, shrinkage of the vessel, disappearance, spasm, and sometimes after just, you need to wait maybe a couple of minutes and you will see that. And this is on the left, that's a vessel before treatment. In the middle slide, that's a minute after treatment, and you can see the darkening of the vessel. So that is a successful coagulation of the vessel, and I know this vessel will disappear. If you don't see the clinical endpoints, your settings are incorrect, you then need to readjust your setting and shoot again until you get the right clinical endpoints. And on the right hand, you will see nice clearance without any scarring or dyspigmentation. Can I have the next slide, please? Another example. So here you see the fine vessel, so it's going to be a 10 milliseconds. So let me just go through the algorithm. So choose your wavelength. Well, these are superficial vessels on the face, so I can choose the 595. Choose a spot size. Well, I can choose a 10 millimeter spot, or if it's a small area, I can use a 7 millimeter spot. It will take me a few longer seconds. Fine. So let's stick to 7 millimeter spot. Choose pulse duration. I see vessels, so that's going to be 10 milliseconds. Fine. So then I have 7 millimeter spot already. I have 10 millisecond already. Then I need to choose my fluence because that's the next thing. Okay. So I can tell you from experience that for a 7 millimeter spot, 10 milliseconds, your purpuric threshold is going to be around 10 joules. Okay. So if you want to be safe, you can go to 8, 8.5, and then you will see a color change, darkening of the vessel, and there you go. If you had used 10 millimeter spots, remember the pulse duration is going to stay the same. The pulse duration is independent from the spot size, and it's dependent only from the vessel size. So if you're using a 10 millimeter spot, you're going to stick to 10 milliseconds. Okay, I can again tell you that from experience, the purpuric threshold is around 7.58 joules. So you're going to use something like 6.5 joules, and you're going to get nice clearance. Can I get the next slide, please? So this is a recent article that was published by Dr. Eric Bernstein from Philadelphia. And the reason I'm showing this is because he published his experience and his results with the largest spot size, which is the 15 millimeter spot. Remember, this is the largest round spot size that we have with the Vbeam Prima with very nice results. So can I have the next slide? So here is the question. Those of you who have the Vbeam Perfecta would have been using the 7 or the 10 millimeter spot successfully in the management of rosacea. Does it matter if you use a larger spot size? Can I have the next slide, please? And it does, because look at the look at the tissue reaction with a larger spot size for the same fluence. So here you can see the fluence is the same, but the tissue reaction is much different with a larger spot size compared to a smaller spot size. Because what happens with a larger spot size is you're getting better depth of penetration, less wastage, less reflection, and less scattering. In other words, the photonic energy, the light has a much more efficient photonic energy at deeper levels with a larger spot size. And more efficient photonic energy basically means better biological interaction. So we're going to get better results. Can I get the next slide, please? And this is exactly the reason why I published this article very recently with the Vbeam Prima, because before I had the Vbeam Prima, I was working with the Vbeam Perfecta. And what we saw is a phenomenon that we all know, that you can plateau with port wine stains and you no longer get response, which we call them the laser-resistant port wine stains. And if you look at one of the great papers that was published last year in Lasers and Surgery in Medicine, which I have referenced in this article, they looked at laser-resistant port wine stain cases through imaging, and they found that the key reason for resistant port wine stains for laser treatments is depth of vessels. The vessels are too deep for the spot sizes that we were using. So when I had these patients who were labeled as laser-resistant port wine stains with the Vbeam Perfecta having several treatments, when I moved them over to the 15mm spots of the Vbeam Prima, I suddenly started to see results and clearance, and this is why I published this. So a larger spot size does mean more efficient fluids. So with the rosacea, it's exactly the same. Can I get the next slide, please? So I will show you some examples. So this is just one single treatment. Patients with rosacea or erythema, I promise them, I tell them, I promise I will get you results in one single session, because you must nail it and you must get the results in one single session to impress the patients, and so that they can have faith and trust in the treatment in yourself. So how do I approach this? Sorry, can I go back? Yes. So remember, there are visible vessels, so I can choose the 3 by 10mm spot. Okay. Now remember, I said if you see a vessel, it's 10 milliseconds. But if you see laterally in the preauricular area, just in front of the ear, some of the vessels are very, very large and thick. So this is where you can use a 20 milliseconds. And I know that some doctors who are experienced will say you would use an NDAG, and yes, you can use an NDAG, and I can use an NDAG here. But I can also assure you that if you use the pulse dye laser correctly, and that is with a 20 millisecond, and do 2 passes, you will get very nice color change in these vessels. Then I do the layered approach, which is going very deep. That's with a 15mm spot. I stay at 10 millisecond because I could see vessels, and I go at low fluence below the purpuric threshold. And by the way, if you don't know the purpuric threshold, just go lateral to the face where there is erythema. Just explain to the patients you're going to do 2 shots, one at a relatively high fluence, and then go 1 joule below that. Do these shots, wait a couple of minutes, and see if you develop purpura, and then you just go a joule below that. When you stop developing the purpura, that's your subpurpuric fluence. So I do a pass of that to treat the deeper components of the vessels, and then a more superficial pass, which I would do in the lighter skin types, but with the darker skin types, I'll just limit it, the first treatment, to 1 pass with a 9mm spot. Can I get the next slide, please? Okay, so here you can see that's the Vbeam Prima, and watch carefully the clinical endpoint. What you will see in this case, you will see transient darkening. See, transient darkening, and it will fade over the next few seconds. So that is transient purpura. Okay, this is a great clinical endpoint to get for diffuse erythema, for post-acne erythema, for poikiloderma observans. If you get this subtle temporary darkening for a few seconds and it disappears, I guarantee you will get success. Because what's happening here is the oxyhemoglobin, which is red, has converted into methemoglobin, which is that bluish gray. And this conversion of oxyhemoglobin to methemoglobin only happens at 65 degrees Celsius. And because I'm using a 6 milliseconds here, because I can't see individual vessels, once again, I remind you, as long as you heat the vessel to 65 degrees for longer than 1 millisecond, in this case it was 6 milliseconds, you're going to get coagulation of the vessels. If you are worried that you might get 1 or 2 areas of purpura, then just go a joule below this. So just go 1 joule below this, wait a couple of minutes. If you don't see any purpura, then carry on. Okay, next slide, please. So yeah, so once again, these cases, you should really clear them with 1 to 2 sessions. So once again, the approach here is the linear elliptical spot size. So that's the 3 by 10 millimeter spot. I see vessels, I'll stick to 10 milliseconds. The larger vessels, I'll go to 20 milliseconds. Treat these, then change the spot size to the round spot size. If you have the Vbeam Prima, use the 15 or the 12 millimeter. If you have the Vbeam Perfecta, the 10 or the 7 millimeter spot. If you see the vessels, you stick first with the 10 milliseconds. You'll choose the fluence just below purpura. You'll do 1 to 2 passes. If it's just diffuse erythema, like on the right-hand side, if he comes back and he says, I want another session because I want to reduce that diffuse redness, I don't see individual vessels. In this case, I'm going to be choosing a 6 millisecond pulse duration. And after 2 to 3 sessions, when it becomes very, very faint and light, I will then go down to 3 milliseconds, because what's happening, the vessels that you could see on the left-hand side, they are large, minimum 0.1 millimeter, so the thermal relaxation time is 10 milliseconds. And then all you see is diffuse redness, so that's 6 milliseconds. And then very, very light pink, so the vessels are extremely small, then the thermal relaxation time is going to be even shorter, such as 3 milliseconds. Next slide, please. And I don't know about you or not, but I do colorimetry. So this is a colorimetry I use to measure hemoglobin. And you can see on the left-hand side, you can see the dense color where there is a lot of redness. And then after one single session, you can see the reduction. And I find that useful because I show that to patients and I give them the objective reduction in the redness, not just 2D imaging, but the use of colorimetry. Next slide, please. Okay, so we are talking about rosacea, and Dr. Zeina, as I said, gave an excellent talk on the management of rosacea. And what struck me is the revised classification, the key paper that was published in 2017 with the revised classification, which essentially showed that you need to have redness. You need to have redness in order to diagnose rosacea. It was the key diagnostic factor, the centrofacial erythema, and if you look at the major criteria, it was flushing, papulopustules, telangiectasias. So vessels and redness is a key component of rosacea. And then the question is, look, the thing is about rosacea, it's not an all or nothing. It doesn't have to be either a laser or a systemic treatment or a medical treatment. You can clearly combine these two. And I've been combining these two for years now. Okay, there is absolutely logic for combining whether it's topical or systemic treatment with the pulse dye laser, because what you're doing is you're coagulating all these vessels, you're treating the flushing, you're treating the background redness, you're controlling the vascular components. Now I can go as far as saying that you also improve on the inflammatory components of rosacea, and there are some papers to back that up. Remember, oxymetazoline and brimonidine are only licensed for symptomatic relief of the flushing and redness, not for fixed redness and for telangiectasias. Okay, so the pulse dye laser works well. This is a very nice article, one of many other articles, by the way, on the combination of the pulse dye laser with systemic or topical treatments. But what has happened here, they randomized two groups of patients, one group just purely on oral minocycline and another group on the combination of oral minocycline and the pulse dye laser. And to no surprise, the combination group went faster into remission and stayed in remission longer. It makes sense because you're also controlling the vascular component. There is no concern about photosensitivity. I've been doing it for years. That's not been reported. And now we know that there are many other articles, even combining lasers with isotretinoin, which, as we know, was meant to be very photosensitive. So with the short pulsed durations light, there is no concern. The concern is mostly with the shorter wavelengths and with the longer exposures, such as, for example, an LED lamp. Can I have the next slide, please? And this is just another article, just to make you reflect and think and perhaps spend some time to do some literature research, that the pulse dye laser also has reduced the facial Demodex. So the Demodex follicularum count has also been changed, because what the pulse dye laser does, it doesn't just coagulate vessels, it changes the environment of the skin as well, and that is through suppression also of substance P, for example. There are numerous studies which have shown that by using the pulse dye laser, there is a decrease in substance P. And by the way, that's one of the mechanisms on how it works in psoriasis. But we know that rosacea patients, particularly those rosacea patients with very high levels of sensitive skin, have upregulated substance P. And by simply using the pulse dye laser, we're suppressing the substance P, we're controlling also the sensitive skin. There's also a very nice study showing that the pulse dye laser reduces the TRVP, which is the TRVP receptors that are highly excited in patients with rosacea, that gives them that burning sensation. And by using the pulse dye laser, we are switching those off. So the take-home message is that the pulse dye laser is not just there for a single vessel, and is not there just to get rid of the erythema of the rosacea, but it improves the condition itself, including the inflammatory components and the long-term outcome. Can I have the next slide, please? So this is an example of some of the difficult cases of rosacea where I've combined the vascular laser with the topical or systemic treatment. So the combination works. Next slide, please.
I would like to remind our audience that you can use the question mark symbol to address questions to our panel, Dr. Zeina and Dr. Firas. We already have a very big number of questions and some very interesting questions. So I'll start right away. I have a question here about treatment of vascular melasma. You just target the melanin and eventually the vascular component reduces as inflammation reduces. Would you treat the pigment and the vascular element separately?
Okay. Dr. Zeina?
Definitely, it's been proven that melasma has vascular component and it makes melasma worse. Probably starts with the vascular component. I wouldn't treat first with vascular laser. I would wait till I bleach the skin with a hydroquinone or any other bleaching agent, and then do the vascular laser at the end. Again, we need to be really careful. These patients, you don't want to make more harm. When dealing with darker skin types who are more prone for melasma, we need to be extra careful with any type of with lower energies. Don't be heroic. You don't want them to get worse.
Yeah, if I may add, I totally agree with you. I think pulsar laser and melasma is something that it's a bit of a hit and miss. It can certainly work if there's a vascular component. So what I do, I use the colorimetry. So that is a 3D device that can measure both hemoglobin as well as melanin. And if I see in a melasma patient a lot of hemoglobin, then I will introduce a pulsar laser. But I totally agree with you. Low fluence, low settings. And you know, sometimes it's difficult, but yeah, topical treatments. If you're talking about melasma, I'll be very clear. Topical treatment remains my first line treatment for melasma.
So next question is actually a request to give a little bit more idea about the use of Botox in treating rosacea.
Okay, so botulinum toxin, yeah, Botox for rosacea works nicely in the flushing component. It doesn't really work that well for the fixed redness. So if you have the vessels or fixed redness, it doesn't work that well, but particularly for those patients who get the flushing. Most of the studies, one of the earlier ones came from Chicago, from Stephen Dayan, and subsequent studies from Korea. They used a 2.5 ml dilution and intradermally, a centimeter apart, 15 to 20 units per cheek. Now I found, and I'm trying to publish this now, that by just using a different dilution of 4 ml, using a total of 15 units, but very superficially injecting, that can work particularly well in the patients with flushing. So what I tend to get them to do is to wash their face with warm water, just gently tab on the cheeks, get some more erythema, get some of that flushing, and then do meso Botox injections very superficially. And then you can repeat that after about 2 to 3 months, and it works nicely. I tell you what, it works very nicely in combination with the pulsar laser. So you do your pulsar laser first, and then you can do some meso Botox. So it's 2.5 or a 4 ml dilution, no more than 15 to 20 units in each cheek. So we're talking about very small aliquotsif injections. Very important to place it superficially. No cases of muscle weakness or asymmetry. No problems with that, using that dilution and the right technique, injecting it very superficially. Okay.
Dr. Zeina would like to comment, or should we move to the next? Okay.
Move, so that we have more chance to answer more questions.
Yeah, you said there are many questions.
Yeah, we have a big number. So next question is, can we directly start treatment of rosacea with PDL if pustules and papules are present?
We might have different opinions. I usually start them on oral treatment and creams before I start the pulsar laser because I find it painful and the skin is very irritated. So I would just treat to put them under control, and then I'll deal with the vascular component.
Yeah, I mean, I agree with that. There are occasions where I would start, and that is for those patients, you know, who say I can't take anything I put on my face burns or stings, I'm allergic to everything. These type of patients, for some reason, I tend to attract. I will, but I totally agree with Dr. Zeina. It's to start medical treatment first, get control of the inflammatory component. I will start, however, using the pulse dye laser when it's under control. So they're getting fewer papules and pustules. They're really worried about the erythema, but it's in the right direction. I will introduce the PDL. So I agree. I will put them on something first. I want to see an improvement, then I will start. But I have treated patients with papulopustular rosacea with pulse dye laser. I have. But I agree. The approach is to start with the topical and the systemic treatments and then introduce the vascular laser afterwards.
But I have one quick comment about that. Also, talking about Middle Eastern skin, is that they tend to pigment. So if they're very inflamed papules and pustules, and you're treating them again with laser, you have more risk of side effects. That's why I would be more careful.
Okay, you mean PIH?
Yes, I mean they are inflamed. The papules and pustules basically are very inflamed. So you don't want to, you know, increase the inflammation by high energies.
Yeah. Okay. Thank you.
Next question will be, what is the best purpurogenic dosage for PDL? How to choose the perfect dose related to patient skin types, especially darker skin types?
Dr. Zeina?
You can go ahead.
Okay. I mean, look, this is the hardest question of what exactly is the right setting for.
That's why I told you to say, that's why I asked you to answer it.
Okay. Yeah. Well. Okay. I hope you're thinking the same. It's very difficult, but what I would say is that depending on what you're treating, your endpoint is important. So, for example, if we're treating a port wine stain, there's no way around it, really. You will gonna have to get the purpura, but probably just go for maybe a little bit of a lighter purpura, and cool the skin afterwards. And you know, you might just get temporary pigmentation, but it's the key is the clinical endpoint. So the difference is probably going to be with the intensity of the purpura. So in other words, just to give an answer, you're going to stick to the pulse duration, regardless of the skin type. Okay, because if you need purpura, you're going to have to choose a pulse duration. The things that you can do is maybe just play a little bit with the cooling, that you have extra protection and extra cooling to the surface of the skin, some post cooling afterwards, and maybe not to go for the very intense purpura, but just go on the lower end of the purpura. That's how I would do it. Dr. Zeina?
I mean, I agree with you. I would just be careful. I mean, with other systems, not necessarily with Vbeam, that too much cryogen can also cause a permanent post-inflammatory hypopigmentation. So it is a balance with the cryogen. We cannot cool too much also, because the cooling might also hurt the skin. And if we're dealing with a child or an infant, they can be, they're not exposed that much to the sun. But if we're dealing with adults with port wine stain, I would prepare the skin before with bleaching agents before any laser procedure.
Yeah, I totally agree with you. Actually, that publication that I published on the port wine laser resistant port wine stains, if you saw on the article, both of them were higher skin types. And I used a 15mm spot with the Vbeam Prima, but in the contact cooling handpiece. And I think I totally agree with you. I think the contact cooling handpiece has an advantage over the cryogen in that you can increase the cooling without increasing the risk of PIH. I definitely see that with leg vessels. With leg vessels, when I'm treating with the NDAG, I see some cases of cryogen-induced post-inflammatory hyperpigmentation, but now when I moved over to the contact cooling, I'm seeing less. So yeah, I totally agree with you.
Next question is a hands-on question, I think. If I don't see the endpoint from the first trial, how long should I wait before I start with the next pass or the next try?
I mean, it depends. If it's a light skin type, pretty much immediately afterwards. Maybe if it's a darker skin type, you want to just cool, wait until the reaction is over. But it depends on the setting. If your setting was extremely low, nothing has happened probably. So I would start within minutes, really.
Agreed. It's usually within minutes.
How long should the patient expect to be in remission for after a successful PDL laser to diffuse erythema?
I usually tell patients they need around 4 to 6 treatments, maybe with the more advanced lasers or more aggressive treatment, 2 to 3 treatments, but there always, this rosacea is there. It's a chronic problem. It will come back. So they would need a maintenance at least once per year to keep their skin fine. I mean, it depends on the patient, the sun exposure, the triggers, but usually it's a chronic condition and we're not really curing rosacea with the laser. We're just treating what we have there. Of course, the relapses will be less probably, but it's still there is a chance that it can come back.
I totally agree. And I see that with patients, for example, who want to have a very active life and do a lot of exercise and outdoor activities, they tend to are exposed more to sunlight and they tend to get more rosacea back. So I explain to everyone, it depends partly on the triggers and how effective you are in using the sunblock and reducing those triggers. But to make it simple, I usually tell my patients, the initial treatment is 3 to 6 sessions. And then we are doing 1 to 2 maintenance sessions a year. So once every 6 months or once every 12 months. That's how I generally explain it to my patients.
Okay, next question. I want to ask about the concern of photosensitivity when it comes to laser concomitant treatment with minocycline or isotretinoin.
I think
Never
you answered. Yeah.
Not a problem. Never had that. Lots of papers about it. Let me explain briefly. 2 things. The photosensitivity relates more to the shorter wavelengths. It's more really to the UV range and less so with the visible light. That's one. But secondly, it's also related to the total dose and the duration of exposure. So probably if it's a blue light LED, then maybe yes, there is an issue. The blue light is very, very close to the ultraviolet range. And as you know, with an LED, the exposure time is longer. But for a millisecond yellow light, which is the pulsar laser, no issues whatsoever, and I've not seen it. Dr. Zeina?
Okay.
Same.
Next question, please.
Next question is, what are the preferred parameters of PDL in case of hemangioma? Any specific parameters on the ulcerative parts?
I will answer this question. Usually, we need the short pulse durations for angiomas and low energy. So if we are using, for example, 7 millimeter spot size, I would go around 7 joules, 6.5 to 7 joules. And if we're using higher spot size, I will even go lower, 4 to 4.5 joules.
Yeah, absolutely. So it's subpurpuric with a short pulse duration.
Yes.
Okay. So next question is, what is the approach for treating nasal telangiectasia? I have many cases treated by 595 and 532, but refilled in a couple of weeks. Are there any tips or tricks for these ones?
You want me to? Okay, I see many of those. Well, I see many of those because they're very common in skin types 1 and 2 adults here. So here is the following. First of all, it's nice to do the combination of the 3 by 10 millimeter spot size, treat the individual vessels. Then I always like to do a second pass with the round spot size to treat the background erythema, because remember, these are vessels, but in the background there are some tiny little vessels. So to reduce the recurrence, what I found is that I use the 3 by 10 millimeter spot. So typically, if it's a red small vessel, 10 milliseconds. For the quite thicker one on the nasal ale on the side, 20 milliseconds. And then I want to see a contraction or a color change, then I will use a 7 or a 10 millimeter spot, 10 milliseconds, and subpurpuric doses, 1 or 2 passes. It can come back. So here's what you can do. If it comes back again, the next approach is to do pulse tacking. So you can do 2 or 3 pulses on the individual vessel in lighter skin type patients. The third thing you can do is to just do purpuric setting and just blast the vessel if it's not responding. But I think the trick is to do the dual approach of treating the individual vessels and then treating the background erythema with a round spot size. To add, there was a recent article that looked at the failure rates and the unresponsive cases of nasal telangiectasias. And one of the key factors was hypertension and calcium channel blocker use, which makes sense because when you have hypertension, you have an increased intra-arterial pressure, and when you're using calcium channel blockers, in a way, you're resisting the coagulation and endothelial contraction by the pulse dilators. So what I have noticed, because I see many of these men in their 50s with these deep vessels on the side, I'll ask them, do you have hypertension? And are you on a calcium channel blocker? Because if they do, I explain to them that the failure rate is higher and the relapse rate is higher too. Dr. Zeina?
Yes, I mean, I agree with everything you said. They are sometimes frustrating. They come back. Purpuric settings sometimes help. Just have to tell the patient you need to have some purpura for a week or 10 days, and then it is better. Sometimes I use 40 millisecond pulse duration with very high energy if the vessels are very large, more than, so sometimes, most of the time, 20 or 10 millisecond pulse duration.
Yeah, thank you.
Okay, I think we should conclude soon. I'll take only a couple of more questions. I already thank our doctors for generosity. We exceeded our original time. So a question is about the recommended interval between the sessions in treating ecchymosis and acne vulgaris using PDL.
You can go ahead.
Okay, well, I mean, these are two different conditions. For ecchymosis, you can repeat after 48 hours if you're not seeing the results. Because remember, with ecchymosis, it will only work really within the first 7 to 10 days. And thereafter, once it starts to get green and change in color, then there's less response. So let's say you do filler today and the patient rings tomorrow, the next day, and says, well, I have bruising. So you can certainly use the settings that we explained with the PDL, and then you can retreat after 48 hours if there is no improvements. You can, and I have done so. So that is with ecchymosis. So every 48 hours until up to day 10, and thereafter it's less likely to work. For acne vulgaris, that's the only condition where my interval is shorter to 2 to 3 weeks, and that is because the initial studies on pulse dilator and acne has also shown that you get repopulation of the bacteria after 2 to 3 weeks. And I find that if I use the longer intervals, that the patients are getting less results. Remember, even from a lot of the evidence using the LED blue lights, it's often 2 to 3 times a week for a few weeks. So my typical gaps or intervals for, let's say, rosacea or diffuse redness would be 4 to 6 weeks. But acne vulgaris is the only condition where I would shorten that to 2 to 3 weeks. You have to take into consideration, of course, the sensitivity of the skin and the skin type. So in light skin type patient, there is no problem. And remember, these are non-purpuric settings, so there is no issue with purpura lasting for a week or 10 days. Dr. Zeina?
Nothing to add.
Okay.
Perfect.
We take the last question then.
The last question is actually from our side in MDed, and we'll direct it to both of you consequently. Dr. Zeina, can you give us your pearl of wisdom on your experience with PDL in different vascular applications?
Pulse dilator is one of my favorite lasers, really. Not because you're MDAD, not because of any conflict. It is one of the best lasers I use daily for multiple indications. It's a safe laser, effective laser, and has multiple uses, multiple indications. Dr. Firas.
Are you asking me the same as well?
Probably.
Yes, exactly,
No?
Dr. Yeah. Let's
Oh, yeah,
call
I mean,
it take-home lesson or your pearl of wisdom with the PDL overall in vascular applications.
I mean, I absolutely love the PDL, and many doctors, many colleagues around the world know me as the vascular laser guy, because I'm a dermatologist, and what I see are conditions that I can target and treat with the pulse dye laser. So I see the acne, I see the rosacea, I see the diffuse redness, I see the scars, I see the red stretch marks, and many other conditions that you can treat with. So it's the volume of patients, the type of patients that I see, and the number of treatments that I can do with a pulse dye laser, it's the one type of laser I can't really live without. We once had an incident where it was out of action for 2 weeks and we could really see the difference. So many angry patients and so many patients who had to be rebooked. So I can't live without my pulse dye laser.
But one final comment, 2 comments, that really every laser, there's no laser that is completely safe. It really depends on the operator, physician, should be a physician who's trained in dermatology or other specialties that deal with the skin, to know the endpoints, to know when to treat, to avoid side effects. We don't do no harm with lasers. You need to know it inside and out before you use it on any patient. And please always be on the side of being less aggressive, especially in the Middle East, especially in this area where we live, where we have a lot of sun and darker skin types. That's very important. Watch out for the eyes. Always protect the eyes. Always protect the skin. Look at the skin and don't misdiagnose a melanoma or mainly a melanoma, a melanotic melanoma, or a melanoma that looks like angiokeratoma. Not everything that is red is amenable to vascular laser. Always have index of suspicion. At the end, we're physicians, we're trained to diagnose skin diseases. We need to know what we're treating. Not everything that is red can be treated with the laser. That's my final comment.
And if I
Well
could,
said, Doctor.
if I could add,
please go ahead, Doctor, first.
Yeah, I totally agree, 100%. I think the problem is, if I'm being honest, that many might think it's easy. They just get settings and they think the vascular, or there is this thought that the pulse dye laser is one of the most harmless lasers, and you won't get side effects or complications. That's absolutely not true. I have seen some serious complications with the pulse dye laser. I think the key message is you have to understand the pathology of what you're treating. You have to understand the clinical endpoints. There's a very good paper by Rox Anderson about the bad endpoints. So not just the good clinical endpoint, but what is bad and what you should not see. As Dr. Zeina says, demographics are important. When you're dealing with a skin type 4, is very different from dealing with a skin type 1. And if you're treating in a sunny climate, it's different from a non-sunny climate. So yeah, absolutely. I totally, entirely agree with what you said about the safety and the difficulty.
And there is an article that we published with my colleagues that also shows some cases of misdiagnosis that were treated not only with vascular laser, with pigment laser. So always have a high index of suspicion whenever you feel something is not right. Biopsy before.
Absolutely. I mean, I still vividly remember one of my senior colleagues who was a laser expert. He actually presented a case of eccrine angiomatous hamartoma, which is a very rare condition, but that presented really with red tumors, and the biopsy was done, which is an eccrine angiomatous hamartoma. No response whatsoever to the vascular lasers, and that was a colleague who was very experienced with vascular lasers. And it just goes to prove and to show that not everything that's red it's treated with a vascular laser.
Definitely, that's our final message. And thank you so much.
Thank you, Dr. Zeina. I agree with you. No, there is no one size fit all, and there is no magic in it. It needs experience and following the guidelines. I just wanted to let you know how grateful we are for your time and beautiful effort and presentation today. I'm getting tens and tens of thank you messages and positive vibes from our attendees, and everyone is saying to you, thank you, Ramadan Kareem, amazing presentation, beautiful content. And they want you to stay, but we need to end it anyway at one
Thank
point.
you very much, Ramadan Kareem.
Thank you, Dr.
Ramadan Kareem.
Thank you very much. And I invite our attendees. We have a survey at the end of this, which help us always to improve our content and webinars and activities. So please spare about 10 to 15 seconds to go through the survey. Thank you everyone for joining us. Thanks for the 350 doctors who spared a couple of hours to sit and to listen to the sharing experience by our experts, Dr. Zeina Tannous from Lebanon, Lebanese American University, and Dr. Firas Al-Niaimi, consultant dermatologist from Harley Street in London. Thank you everyone, and we will see you on the next activity from Meddet. Have a great day.
Bye.
Bye.